Modes of mechanical ventilation are one of the most important aspects of the usage of mechanical ventilation. The mode refers to the method of inspiratory support. In general, mode selection is based on clinician familiarity and institutional preferences. Since there is a paucity of evidence indicating that the mode affects clinical outcome, the most frequently used forms of volume-limited mechanical ventilation are intermittent mandatory ventilation and continuous mandatory ventilation. There have been substantial changes in the nomenclature of mechanical ventilation over the years, but more recently it has become standardized by many respirology, pulmonology groups. Writing a mode is most proper in all capital letters with a dash between the cycle and the strategy. A taxonomy for mechanical ventilation. The taxonomy is a logical classification system based on 10 maxims. A ventilator design 10 maxims. A breath is one cycle of positive flow and negative flow defined in terms of the flow time curve. Inspiratory time is defined as the period from the start of positive flow to the start of negative flow. Expiratory time is defined as the period from the start of expiratory flow to the start of inspiratory flow. The flow time curve is the basis for many variables related to ventilator settings. A breath is assisted if the ventilator does work on the patient. An assisted breath is one for which the ventilator does some portion of the work of breathing. For constant flow inflation, work is defined as inspiratory pressure multiplied by tidal volume. Therefore, an assisted breath is identified as a breath for which airway pressure rises above baseline during inspiration. An unassisted breath is one for which the ventilator simply provides the inspiratory flow demanded by the patient and pressure stays constant throughout the breath. A ventilator assists breathing using either pressure control or volume control based on the equation of motion for the respiratory system. Providing assistance means doing work on the patient, which is accomplished by controlling either pressure or volume. A simple mathematical model describing this fact is known as the equation of motion for the passive respiratory system. Pressure equals plus. In this equation, pressure, volume, and flow are all continuous functions of time. Pressure is actually a pressure difference across the system. Elastance and resistance are parameters assumed to remain constant during a breath. Volume control means that both volume and flow are preset prior to inspiration. In other words, the right-hand side of the equation of motion remains constant while pressure changes with changes in elastance and resistance. Pressure control means that inspiratory pressure is preset as either a constant value or it is proportional to the patient's inspiratory effort. In other words, the left-hand side of the equation of motion remains constant while volume and flow change with changes in elastance and resistance. Time control means that, in some rare situations, none of the main variables are preset. In this case only the inspiratory and expiratory times are preset. Breaths are classified by the criteria that trigger and cycle inspiration. The start of inspiration is called the trigger event. The end of inspiration is called the cycle event. Trigger and cycle events can be initiated by the patient or the machine. Inspiration can be patient-triggered or patient-cycled by a signal representing inspiratory effort. Inspiration may also be machine-triggered or machine-cycled by preset ventilator thresholds. Patient triggering means starting inspiration based on a patient signal independent of a machine trigger signal. Machine triggering means starting inspiratory flow based on a signal from the ventilator, independent of a patient trigger signal. Patient cycling means ending inspiratory time based on signals representing the patient-determined components of the equation of motion. Flow cycling is a form of patient cycling because the rate of flow decay to the cycle threshold is determined by patient mechanics. Machine cycling means ending inspiratory time independent of signals representing the patient-determined components of the equation of motion. Breaths are classified as spontaneous or mandatory based on both the trigger and cycle events. A spontaneous breath is a breath for which the patient both triggers and cycles the breath. A spontaneous breath may occur during a mandatory breath. A spontaneous breath may be assisted or unassisted. A mandatory breath is a breath for which the machine triggers and/or cycles the breath. A mandatory breath can occur during a spontaneous breath. A mandatory breath is, by definition, assisted. There are three breath sequences: continuous mandatory ventilation, intermittent mandatory ventilation, and continuous spontaneous ventilation. A breath sequence is a particular pattern of spontaneous and/or mandatory breaths. The three possible breath sequences are continuous mandatory ventilation, intermittent mandatory ventilation, and continuous spontaneous ventilation. There are 5 basic ventilatory patterns: VCCMV, VCIMV, PCCMV, PCIMV, and PCCSV. The combination VCCSV is not possible because volume control implies machine cycling, and machine cycling makes every breath mandatory, not spontaneous. A 6th pattern, TCIMV, is possible but rare. Within each ventilatory pattern there are several variations that can be distinguished by their targeting scheme. A targeting scheme is a description of how the ventilator achieves preset targets. A target is a predetermined goal of ventilator output. Examples of within-breath targets include inspiratory flow or pressure and rise time, tidal volume, and constant of proportionality between inspiratory pressure and patient effort. Examples of between-breath targets and targeting schemes include average tidal volume, percent-minute ventilation, and combined PCO2 volume, and frequency values describing zone of comfort. The targeting scheme is what distinguishes one ventilatory pattern from another. There are 7 basic targeting schemes that comprise the wide variety seen in different modes of ventilation. Set point: a targeting scheme for which the operator sets all the parameters of the pressure waveform or volume and flow waveforms. Dual: a targeting scheme that allows the ventilator to switch between volume control and pressure control during a single inspiration. Biovariable: a targeting scheme that allows the ventilator to automatically set the inspiratory pressure or tidal volume randomly to mimic the variability observed during normal breathing. Servo: a targeting scheme for which inspiratory pressure is proportional to inspiratory effort. Adaptive: a targeting scheme that allows the ventilator to automatically set one target to achieve another target. Optimal: a targeting scheme that automatically adjusts the targets of the ventilatory pattern to either minimize or maximize some overall performance. Characteristic: intelligent: a targeting scheme that uses artificial intelligence programs such as fuzzy logic, rule-based expert systems, and artificial neural networks. A mode of ventilation is classified according to its control variable, breath sequence, and targeting scheme. The preceding 9 maxims create a theoretical foundation for a taxonomy of mechanical ventilation. The taxonomy is based on these theoretical constructs and has 4 hierarchical levels. Control variable, breath sequence, primary breath targeting scheme, secondary breath targeting scheme. The primary breath is either the only breath there is or it is the mandatory breath in IMV. The targeting schemes can be represented by single, lowercase letters. Set point equals S, dual equals D, servo equals R, biovariable equals B, adaptive equals A, optimal equals O, intelligent equals I. A tag is an abbreviation for a mode classification, such as PCIMVs, S. Compound tags are possible, e.g., PCIMVOI, OI. How modes are classified. Step 1. Identify the primary breath control variable. If inspiration starts with a preset inspiratory pressure, or if pressure is proportional to inspiratory effort, then the control variable is pressure. If inspiration starts with a preset tidal volume and inspiratory flow, then the control variable is volume. If neither is true, the control variable is time. Step 2. Identify the breath sequence. Determine whether trigger and cycle events are patient or machine determined. Then, use this information to determine the breath sequence. Step 3. Identify the targeting schemes for the primary breaths and secondary breaths. Example mode classification. Mode name. A. C. Volume control. Inspiratory volume and flow are preset, so the control variable is volume. Every breath is volume cycled, which is a form of machine cycling. Any breath for which inspiration is machine cycled is classified as a mandatory breath. Hence, the breath sequence is continuous mandatory ventilation. The operator sets all the parameters of the volume and flow waveforms so the targeting scheme is set point. Thus, the mode is classified as volume control continuous mandatory ventilation with set point targeting. Mode name. SIMV volume control plus the operator sets the tidal volume but not the inspiratory flow. Because setting volume alone is a necessary but not sufficient criterion for volume control, the control variable is pressure. Spontaneous breaths are allowed between mandatory breaths so the breath sequence is IMV. The ventilator adjusts inspiratory pressure between breaths to achieve an average preset tidal volume, so the targeting scheme is adaptive. The mode tag is PCIMVAS. Descriptions of common modes. Assist mode, control mode, and assist control mode. A basic distinction in mechanical ventilation is whether each breath is initiated by the patient or by the machine. Dynamic hybrids of the two are also possible, and control mode without assist is now mostly obsolete. Airway pressure release ventilation. Airway pressure release ventilation is a time-cycled alternate between two levels of positive airway pressure, with the main time on the high level and a brief expiratory release to facilitate ventilation. Airway pressure release ventilation is usually utilized as a type of inverse ratio ventilation. The exhalation time is shortened to usually less than 1 second to maintain alveoli inflation. In the basic sense, this is a continuous pressure with a brief release. Aprv currently the most efficient conventional mode for lung protective ventilation. Different perceptions of this mode may exist around the globe. While Aprv is common to users in North America, a very similar mode, biphasic positive airway pressure, was introduced in Europe. The term Aprv has also been used in American journals where, from the ventilation characteristics, BiPAP would have been perfectly good terminology. But BiPAP is a trademark for a non-invasive ventilation mode in a specific ventilator. Other manufacturers have followed with their own brand names. Although similar in modality, these terms describe how a mode is intended to inflate the lung, rather than defining the characteristics of synchronization or the way spontaneous breathing efforts are supported. Intermittent mandatory ventilation has not always had the synchronized feature, so the division of modes were understood to be SIMV versus IMV. Since the American Association for Respiratory Care established a nomenclature of mechanical ventilation, the synchronized part of the title has been dropped and now there is only IMV. Mandatory minute ventilation. Mandatory minute ventilation allows spontaneous breathing with automatic adjustments of mandatory ventilation to meet the patient's preset minimum minute volume requirement. If the patient maintains the minute volume settings for VTXF, no mandatory breaths are delivered. If the patient's minute volume is insufficient, mandatory delivery of the preset tidal volume will occur until the minute volume is achieved. The method for monitoring whether or not the patient is meeting the required minute ventilation differs by ventilator brand and model, but, in general, there is a window of monitored time, and a smaller window checked against the larger window to decide whether a mechanical breath is needed to maintain the minute ventilation. MMV is an optimal mode for weaning in neonatal and pediatric populations and has been shown to reduce long-term complications related to mechanical ventilation. Pressure-regulated volume control. Pressure-regulated volume control is an IMV-based mode. Pressure-regulated volume control utilizes pressure-limited, volume-targeted, time-cycled breaths that can be either ventilator or patient-initiated. The peak inspiratory pressure delivered by the ventilator is varied on a breath-to-breath basis to achieve a target tidal volume that is set by the clinician. For example, if a target tidal volume of 500 milliliters is set but the ventilator delivers 600 milliliters, the next breath will be delivered with a lower inspiratory pressure to achieve a lower tidal volume. Though PRVC is regarded as a hybrid mode because of its tidal volume settings and pressure-limiting settings, fundamentally PRVC is a volume control mode. Continuous positive airway pressure. Continuous positive airway pressure is a non-invasive positive pressure mode of ventilation. CPAP is a pressure applied at the end of exhalation to keep the alveoli open and not fully deflate. This mechanism for maintaining inflated alveoli helps increase partial pressure of oxygen in arterial blood. An appropriate increase in CPAP increases the power to bilevel positive airway pressure. Bilevel positive airway pressure is a mode used during non-invasive positive pressure ventilation. First used in 1988 by Professor Benzer in Austria, it delivers a preset inspiratory positive airway pressure and expiratory positive airway pressure. BPAP can be described as a continuous positive airway pressure system with a time-cycled change of the applied CPAP level. CPAP, BPAP and other non-invasive ventilation modes have been shown to be effective management tools for chronic obstructive pulmonary disease and acute respiratory failure. Often BPAP is incorrectly referred to as BiPAP. BiPAP registered sign is the name of a portable ventilator manufactured by Respironics Corporation. It is just one of many ventilators that can deliver BPAP. High-frequency ventilation. The term active refers to the ventilator's forced expiratory system. In high-frequency oscillatory ventilation, the oscillation bellows and piston force positive pressure in and apply negative pressure to force an expiration. High-frequency ventilation. The term passive refers to the ventilator's non-forced expiratory system. In a HFVP scenario, the ventilator uses pressure to apply an inspiratory breath and then returns to atmospheric pressure to allow for a passive expiration. This is seen in high-frequency jet ventilation, sometimes abbreviated HFJV. Volume guarantee. Volume guarantee, an additional parameter available in many types of ventilators that allows the ventilator to change its inspiratory pressure setting to achieve a minimum tidal volume. This is utilized most often in neonatal patients who need a pressure-controlled mode with a consideration for volume control to minimize volume trauma. Spontaneous breathing and support settings. Positive end expiratory pressure. Positive end expiratory pressure is pressure applied upon expiration. PEEP is applied using either a valve that is connected to the expiratory port and set manually or a valve managed internally by a mechanical ventilator. PEEP is a pressure that an exhalation has to bypass, in effect causing alveoli to remain open and not fully deflate. This mechanism for maintaining inflated alveoli helps increase partial pressure of oxygen in arterial blood. An increase in PEEP increases the power to pressure support. Pressure support is a spontaneous mode of ventilation, also named pressure support ventilation. The patient initiates every breath and the ventilator delivers support with the preset pressure value. With support from the ventilator, the patient also regulates their own respiratory rate and the tidal volume. In pressure support, the set inspiratory pressure support level is kept constant and there is a decelerating flow. The patient triggers all breaths if there is a change in the mechanical properties of the lung, thorax and patient effort. The delivered tidal volume will be affected. The user must then regulate the pressure support level to obtain desired ventilation. Pressure support improves oxygenation, ventilation and decreases work of breathing. Also see adaptive support ventilation.